Good afternoon, ladies and gentlemen. I'd like to thank Professor Datta and his team at NQOCN for this kind invitation. It is heartening to see this sort of tremendous effort that he and the entire team, the network, has put together, and looking at the successes that NQOCN has achieved since its in the short period since its inception. So, and I think that's a testimony to the leadership and the quality that is being driven by Prof. Datta and the colleagues in India. So, well, today's topic may come across as being very specific, and I think one needs to first understand that the importance of context by taking a bird's eye view before zooming into the content. So you'll realize that there are, despite the fact that this is a specific topic, the principles, I'm sure you can understand, are very generic and can be equally applicable to other areas of clinical interest. And it's not just clinical, it could be educational or operational improvement. So I'm grateful to my colleagues, Dr. Sinny Lau and Ravi Swamy, who will spare you from my monologue. For those who are interested in applied educational theory, I hope this webinar, we can try and signpost to you a few principles like bite-sized learning, clarifying context and content, varying the stimuli, and also how storytelling can be a powerful medium. And to some extent, we hope that we can use the live poll. Hopefully the technology will work and really be interactive. So just trying to make sure that the slides move. So struggling with two computers because one doesn't have a video. So I'll start off the first part by focusing on the context, really. Now, in this session, I'd like to share some insights on what a high-quality neonatal service looks like and the importance of having standards. We will then examine the 5M model, which is widely used in aviation safety, and how these principles are equally applicable in clinical medicine. I'll then share some of the other principles underlying how to build a program for skill building and the significance of enabling collaboration and building a safety culture. Sinny will then showcase how we have modeled this approach in our work at London Neonatal Transfer Service over almost 2 decades. So yes, skill building and safety culture doesn't happen very quickly, it takes time. She will then also focus on the content of our clinical and non-clinical simulation program, and I'm sure highlight the importance of team training and how we can achieve this collaboration in practice. Ravi will then take us on a journey of the Neonatal Emergencies Team Training or NEST course, and how this course, this practical course, came from London, and how he and colleagues adapted the course so that it became a program across length and breadth of India. And this was possible not just because we had a lot of resource. No, it was very resource constricted, but it was possible because of the input of colleagues who really became enablers and collaborators. So, and we were all aligned to the vision of doing our little bit in improving the quality of neonatal care in India. And NEST has traveled beyond India to Sri Lanka, Nepal, Middle East, making a real impact. And hopefully we'll showcase a little bit of that impact to you. So what does high quality neonatal service mean to you? And in asking this question, I would like to invite you to think carefully about your local service and local societal need, rather than focusing on the state of art or what is happening in maybe Western world. Recently, I saw a WhatsApp message from a young neonatologist who shared with me the photo of a very small premature baby, and he said this baby was 350 grams and was boasting about his skills in intubating his baby. Well, I thought it was deplorable, and perhaps an extreme example I'm giving you, but what I'm trying to make is a point that we need to ask the right questions and not just do something because we are skilled. Please do not make any mistake that I am not against skill acquisition or discouraging people for aiming at the best possible care. But all I'm trying to perhaps showcase is how Jiddu Krishnamurti said, asking the right question is far more important than receiving the answer. And this if you look at the question in detail, that's where the answer for the problem lies. And this is also the reason, this is also the approach we took in NTS. So when I started with NTS more than a decade ago, we were constantly seeing that despite all the available resources, despite the no lack of skill and knowledge, we were still seeing babies who were hypothermic, babies who had tubes in the right main bronchi, and many other problems. I'm sure you're familiar with these. Now, we kept on asking, why is this happening? It's not because there is no resource. It is perhaps happening because despite the knowledge and the skills, somehow we are not able to apply this knowledge. And that's where the whole concept of human factors came in. So it is this sort of ability to apply your skill and knowledge in any circumstances, especially stressful circumstances. And that's where the NEST program took its birth. Standards are needed. This is a document from UK Department of Health, 2009, and this forms the basis for our design, implementation, and audit of high quality neonatal services in the UK. Now, I'm sure you will have something similar or some standards that are drawn up in each state or country where you are. The question really is, how aligned are you to those standards? And what do you do to achieve those standards? And where are the problems? And what are we doing to address these problems? And that's where I think the key area of input lies. And this is where we need to be thinking collaboratively. And perhaps that's where the whole role of selfless leadership lies as well. Now, skill building is needed to, of course, achieve high quality standards. But the issue is, do we always focus on skill building, or is our focus somewhere else? Often I have colleagues, especially juniors, who say, oh, well, I need a little bit more knowledge, and if I had a little bit more knowledge, I will do better. I would like to actually challenge this notion politely, because I think there are many ways to run. Of course, you could do the theory of how to swim, but unless you have some sort of basis, if you jumped into the water, you might end up like that. But the question is, it's not just theory and it's not just practice. It's the blending of this sort of knowledge and skill, which is important. And there is more to that rather than just the theory and skill. And that's where the whole sort of area of human factors comes in as well. Now, I don't think we can overemphasize the importance of gap analysis and really knowing what is the gap between where we are and where we want to reach is the key to defining the purpose of your program or training that you are about to set up. So, and that's where I think if we don't get this right, we may be providing something, but it perhaps will be of mediocre quality and certainly not high quality. So let me take you through this 5M model, which is used in aviation safety. Now, this model can easily be applied to the neonatal or transport setting. So when I say man, of course, I'm not just meaning, so I mean any of our healthcare workers. And we are on a mission, which is to save or look after that baby or transfer the baby. But in doing so, we need to interact with the machines, which all our technical setup, but our environment is also the key. So that the complex interaction between the man, machine, and medium will result in the outcomes of the mission, which is the care that we provide to our patients. And then there is the wider circle in which how our leaders and managers are helping us achieve this. So we'll touch upon that a little bit later, but the key message is it is that understanding of interaction between man, machine, and medium. And that is where the whole, again, the science of human factors lies. Now, when you look at just the human environment and focus on one area, that's where you perhaps lose the other two areas. And that's where we perhaps lose the importance of the interaction. And I would urge you to look at the interaction in total. We will move on and to the sort of contextual principles that we will highlight in this session. So the importance of collaboration, perhaps, importance of communication, and communications no longer just a human one-to-one communication. It's become much more complex than that now. Everything from your WhatsApp to your data that is going from one monitor to another. How is it that we can have a handle on this communication? And despite the collaboration and communication, how do you enable a culture where people are paying attention to all these things, and yet it is a supportive and collaborative culture? Because I think high quality care definitely needs that sort of high quality culture. Now, underlying this overall learning is this principle that we as human beings, no matter how good we are, how experienced we are, and how excellent we are fallible. So we need others to support us, and we need structures and systems in place that can help us mitigate against the risk of our own humanness. So we need a program that can help us build our competence and our confidence. But this won't happen without the guru. And that's what I would call your experience simulation facilitator, for example. And they would help us learn and acquire these skills over time. And that's where, having many of those processes will build the culture eventually. I'm sure you've come across David Cope's model of experiential learning, which forms the basis of the whole of the simulation work. And I'm sure Sinny and Ravi will perhaps deepen how it is applied in the presentation they will give. So while we focused on the importance of the three areas, I would also say that leadership is really critical, and applied leadership is really important. I will leave you with a video that my friend Dr. Kedar has recorded for us. He is a NEST faculty member, and he is actually showcasing how he's applied the ethos and training to his clinical practice. Ashna, would you kindly play the video, please?
I'll do that.
I have been looking for tools which can help improve the quality of care in my NSU since long. Very soon, I understood that it's largely about people and their interactions which determines the outcome. I was attending a week-long training of trainers workshop regarding facility-based newborn care at Khajuraho in 2014, where I happened to meet Dr. Ravi Swamy and Dr. Praveen Venkatgiri. They presented a short introduction about neonatal emergency simulation team training, that is NEST. I heard about human factors approach in their presentation, which attracted my attention quickly. So when the opportunity came, Dr. Ravi invited me to attend NEST workshop at Bengaluru in 2015. I grabbed this opportunity. Later on, I also organized NEST workshop at Aurangabad in 2016. This has helped me to look at both good and bad incidents through a different approach altogether. Instead of fixing an error on a person, I tried to find which human factor we are operating that has resulted in the error or the problem. And this has helped me to find out the root cause of the problem and eliminate it from recurring. It also helped to spread the right message among staff that they will not be targeted solely or punished for any untoward incident. This fostered an environment of psychological safety, which is of paramount importance in any improvement in healthcare. Human factors approach was probably the first step towards a culture change in my small setup. This approach helped us to improve safety in our NSU care as well. I will give you one example from my unit itself. So one of the baby who had undergone double volume exchange transfusion for RH incompatibility was looking dehydrated. Baby also had bilious aspirates. So I asked my fellow to give a bolus of 20 ml per kg of ringer lactate to this baby. It was 8 a.m. in the morning. It was the time for change of guards for staff and duty doctors as well. The fellow orally told night staff to give the bolus. The night staff gave handover to the morning staff who was new to NIC. And after some time, this new staff was giving the IV bolus. She had just started and she has not informed the other senior staff while giving any IV injection, which was our policy, which is still our policy. And that was noticed by the senior staff. So she asked her, what are you giving? She said, I am giving ringer lactate bolus. But she saw that there is no bottle of ringer lactate near to her. So she asked her to stop and she checked. And she found that it was concentrated ringer lactate vial instead of plain ringer lactate. And this concentrated ringer lactate is 25 times concentrated as compared to the normal ringer lactate. She immediately stopped her and informed the doctors. Corrective action was taken and fortunately no harm to the baby was done. Now this junior staff who was administering this bolus was shivering and crying when she came to my consulting chamber. I consoled her and we took a complete review of the process. And we concluded that first, it was the error by me as consultant who did not follow closed loop communication with the fellow. Second, the error was by fellow who did not write the orders and told it orally to the night staff. The night staff gave handover to the morning duty junior staff who committed the error, which was fortunately caught in time by another senior staff. Fourth was that the bottle of ringer lactate and the vial of concentrated ringer lactate was kept side by side in the drug trolley, which the junior staff could not identify. So we corrected it by shifting the concentrated ringer lactate to red alert area of the drug trolley, which means the drug in this area must be shown to a senior staff or a duty doctor before administration. We made it sure not to administer IV drug without written evidence except in emergency. And also we decided that we will follow S bar for giving handovers to minimize the human errors or mistakes. And by accepting the blame partly by the leader, that is me, we set an example that we doctors are also vulnerable to error. This experience gave staff a lot of courage to speak for patient safety. So this is how the training in NEST helped me to analyze the error and take appropriate actions.
Sinny will continue.
Hello, good afternoon all, and thank you, Syed, for inviting me to talk here today. So I am one of the neonatal transfer registrars, the doctors, and what I'd like to do is just to tell you about NTS, the role of NTS, and how the transport system works in London, and how we've assimilated a training program in the form of simulation as part of the department in order to help improve care and teamwork, essentially. So what I'd like to do, Ashna, is could you kindly run the first poll? What we'd like to do is just get some voices in the room. We're aware that there's quite a few of you, so just to see what transport services there are out there, what you use at the moment, if that's possible.
Okay, so I'm launching the poll right now. Yeah, so I think all the participants will be able to see 3 questions on their screen. And the poll is anonymous, so I would request all of you to actively take part in it.
So hopefully you can all see the questions, but essentially we just want to know whether the place that you're working at the moment, whether you undertake neonatal transfers, and if you do, then who actually does them, whether it's the medical team yourselves, whether you have a private hire or public funded hire. And the final and third question is, if you do your own transfers, who actually goes on these transfers? Whether you have a doctor, a nurse, technicians, none of the above, someone else, then it'd be just interesting to see what goes on everywhere. I'll just give you another half a minute or so. Ashna, can everyone see the answers to the polls?
Yeah, I think you will be able to see the answers. We'll
Yeah,
project it to the participants in another 30 seconds.
Okay, perfect, thank you. So just looking at the moment, it does look like the majority of people do undertake neonatal transfers, and it's normally done by the team themselves that usually involves doctors and nurses, really, which is what we thought. So I'm just going to end the poll now. So sorry for those who've not been able to get their answers in. And then share results. Okay. So what I'm going to do now is just talk a little bit about neonatal transfer service. I'm just going to share my my screen. Can you see my desktop?
Yeah, we can.
Great. Perfect. Right. So just try and move that to the side. So essentially, Neonatal London Transfer Service, the birth of NTS happened because a census was done in 2001, and it found that actually a lot of the transfers in London and southeast of England were delayed for various reasons. That could be because of difficulty getting ambulance vehicles, getting a team together. And the importance of this is because we needed babies to be in the right unit in order to receive the best care and for the best outcomes to be produced. So what happened was a group of doctors, nurses and paramedics were trained, and it was a dedicated team that wasn't necessarily attached to a unit as such, actually just standalone, did the transfers for London. The first mission was undertaken in 2003, and it's been ongoing since and evolved so that there are more emergency teams, and instead of just a daytime transfer service, it actually runs 24/7. From the initial mission that was undertaken, a census a year later was done, and it showed that there was significant improvement of getting babies to the right units at the right time. This is just a map just showing the 600 square mile area that NTS actually cover and the different units that there are. And when I say getting the babies to the right units, that is, for example, if you had a level 1 unit, which is more like a special care, then having an extreme preterm baby delivered there isn't ideal, as you might not have the right resources or the skill sets. So you have to think about how to get that baby from that level 1 to a level 3, for example, with a level 2, which is in the middle, which is more like high dependency. And then you've also got your specialist centres, for example, your surgical units and your cardiac units as well. So we get involved in those transfers too. So there's roughly about 1,200 transfers annually, and the NTS itself consists of 2 emergency teams that has a senior doctor, a nurse and a paramedic. We have an elective team also, which does the daytime transfers. That's normally repatriation, low-risk babies, and also an admin team that are really important for the smooth running of the ops and logistics for the whole the department. And how it works is we're very fortunate in London in that we have an emergency bed service. They call around all the units and ask about what cot availabilities there are in every single unit in London, which means that it makes our lives easier when a referring hospital calls and needs their baby transferred to a hospital. Then EBS have a list of where they can go depending on locality. So ideally babies get transferred to a hospital closest to them. What our role is in the office is that we triage the calls as to whether we need to dispatch straight away, whether it can wait, or whether the elective team can do it. And also we can give recommendations to units about what they need to do with babies, for example, starting inotropes, getting access, maybe tweaking ventilation if necessary. But we can only really make recommendations. It depends on the unit themselves, as they are actually clinically looking after the baby. But if it's just a matter of transfer, then we can just ask for optimization of the baby status and the paperwork, so that when we arrive to transfer, that everything's ready for us to go. And then these are the various transfers that we do. So time criticals are the ones that we need to dispatch within a half hour. They're the ones where we go on blue lights rapidly to the referring centre and to the receiving hospital. Then we have our other emergencies that could just be the preterm babies that need to go to a higher level intensity care unit. And then we have planned emergencies, which are your procedural things like PDA ligation, ROP, planned procedures. So one of the things that Syed had mentioned was about the ethos, about looking after one another, creating a good team morale in order for the best teamwork to happen. And the ways that we do that within NTS are, so we are obviously interprofessional. We have nurses, we have techs, we have doctors. And the idea is forming a culture of shallow hierarchy. That is saying that in a team, we know that the doctors are your clinical leaders. However, there are different aspects within a world of transfer where actually you may not be the most knowledgeable. Therefore, it's empowering your other team members to feel that they can feel assertive enough to say something if they feel that maybe something could be done differently. For example, if there's an issue with the rig, so the incubator, the transport incubator, then hopefully the tech will be comfortable being able to say something. So it's embedding that culture of team working and making every member of the team feel like their opinion is validated. We also have team debriefs if we've had really tough cases, just to allow people again to air their thoughts. And also for anything that they feel could have gone a bit differently, then that can be brought out so that we can learn from it. We also do case-based discussions, and we have outreach sessions, which are for sessions that we do with other neonatal units. So although we are our own department in the form of NTS, we are also part of all the other hospitals, because we actually, we have regular transfers with them. So creating that culture of learning with other units is really important too, because we, from an outside perspective, have a better situational awareness and a bird's eye view, which they actually highly value. And these outreach sessions are actually received quite well. We also have clinical psychologists if people feel that something has affected them a lot, just to ensure the well-being of the team is looked after. And what I want to really speak about is simulation and team building, which has really come into its own in the past couple of years. This is just a picture of one of our case-based discussions. So the whole team, so it's doctors, nurses, techs, and admin, if they're available, sit around the table and we talk about certain cases, talk through from the point of receiving the referral all the way to when we get back to base, and any issues that may have happened throughout that whole transfer gets highlighted. What we can do then is develop simulation scenarios on the back of that in order to learn from any things that maybe could have gone better. And we do that by simulation. So Ashna, if you could set up the other poll, that'd be great, thank you. So what I'd like to do is just ask a question, throw a question out there. I'll just stop my sharing. And that is just to see how many people have actually participated in simulation training before. And if you have participated in simulation training, whether it was high fidelity, low fidelity, or task-based simulation, so, intubations, inserting long lines, that isn't part of a scenario. And if you participated in simulation, whether it was interprofessional, so not just doctors, not just nurses, not just healthcare professionals, like the whole group, so multi-professional. I'll just give you another minute or so just to answer the poll. So just so far, it looks as though it's kind of 2/3 yes, people have participated in sim, 1/3 no, a lot of it actually is task simulation, which is interesting. So not so much a scenario, more about doing certain tasks. And I'll explain why that's interesting a bit later. And about half and half are multi-professional versus not interprofessional, which is interesting. Just give you another 10 seconds or so. Okay. So I'm just going to end that poll. And hopefully you can see the results there. So yeah, 2/3 or thereabouts actually. So more have participated in sim than not. Mostly it's task simulation, and it tended to not, it's half and half, but tended not to be multi-professional. Okay. So I'm just going back to my screen share. Apologies. I'll just grab. So why simulation? And the idea is that you're imitating a real thing, state of affairs or processes. And it actually started off in the military, believe it or not, as a game of chess, then evolved into flight industry. For those of you who have done simulation, you may have heard about the Bromley case, where a lady went for an elective procedure and ended up dying because of multiple errors that happened. And it was actually from off the back of that that simulation became, and human factors came to the fore with regards to medical training and teaching. And why we do it is because actually we know that healthcare, we know that we're all skilled, we all have certain good knowledge base. Otherwise, you know, we wouldn't be doctors, we wouldn't be nurses. But the main thing is actually human factors that cause healthcare errors, and actually 80% of healthcare errors are due to human factors. These are non-technical skills that that simulation is able to tease out and highlight. And the idea of sim is to figure out ways in a safe setting how to mitigate these errors in order to provide better care. So what are human factors? Syed had alluded to what they were already. Let me just move this. But essentially, it's lots of different things, including yourself, your environment, your equipment, other people, how a team working, and all these we know can affect your behavior, your attitudes, and how you react to clinical situations. So by addressing these, acknowledging these, finding ways to overcome these and counteract these might help with the patient care. So we do a lot of simulation in NTS, and what we do is we embed protocols, new processes in. We talk about team working, again, it's interprofessional, and we look at the various human factors that can affect how you manage a clinical scenario. And this is the equipment that we use. So this is our high fidelity simulation equipment. You can see the mannequin in the incubator itself. So that mannequin breathes, it has chest movement, it can move, it can simulate seizures, it can have stridulous noises, and you can see the umbilical cord sticking out. And the idea is that we put the team, so a doctor, a nurse, and the technician in a scenario. For example, this might be a term baby in respiratory failure. And then what we do is, depending on what they do to the baby, we can adjust the observation. So as you can see there on the top right, there's a monitor called simulation monitor. So if they, for example, let's say this baby had a pneumothorax, we can change the observation so the SATs drop, have a bradycardia, and if they respond to the pneumothorax, then we put the SATs back up and the heart rate recovers. Below the sim monitor, there's a ventilation screen, or a fake ventilation screen, that shows the pressure flow loop. And there's an iPad on top of the incubator here that we control everything from. And we use this as part of our simulation, specifically with new doctors or new staff in the back of an ambulance, because we know that doctors, the nurses, they're used to their NICU environment, and one of the main things that they find tricky is actually being in the back of a moving ambulance with restricted space. So we do some induction simulation. Again, it's multi-professional. So in that picture, you can see 2 senior nurses and the technician, because we know that, again, it's about team working. It's not just about a solo clinician, which is very important in effective teamwork to provide good care. We also do standalone equipment training, because at the start we know that getting used to the rig, the ventilators, is highly important, and that just takes place in the storage room. But also to highlight, actually, we've got our fancy equipment, but actually sometimes low fidelity sim provides the richest learning, because you're not looking at the clinical state of a baby necessarily, you're looking at the human factor element of it. So it's about the communication, it's about the graded assertiveness, it's about leadership. And we do a lot of in situ simulations. So we do clinical covering A to E, so airway, breathing, circulation, neurology issues. We also do palliative care transfer ones, difficult airway ones, and also non-clinical ones where we focus on things like communication, graded assertiveness, and processes and protocols. But we've also started incorporating team building games and sessions where it's about abstract cases where we do serious Lego play, for example, and we debrief afterwards about what the communication was like, how the team working worked, and actually they're received very well, as it takes away the clinical context and stress from it all. I just want to spend a few minutes talking about one of the new simulations that we developed, which is around COVID. As we're all aware, in the past year, it's really affected how we've provided care to patients, and that is neonatal cohort included. The importance of creating a COVID sim was really because there was so little understanding as to what was going on. That paper that I just showed was done by one of my previous consultants, looking at the cases of neonatal coronavirus in the UK. And actually what they found was that although it didn't affect the babies very much, we still needed to protect ourselves, protect the team. Also, it was still early on, so we don't have much evidence to say how a baby having COVID affected the team. So the other thing that we had to bear in mind was that there's resource variation in all the different trusts. So there was no national guidance because it was difficult to provide something. So it's how we unify the guidelines as such, or how we come to onto the same page for management of COVID in neonatal cases and neonatal transfers. And what we did with the COVID simulation was actually figure out what learning objectives we really wanted and wrote a scenario around that. So really the main issues were about safety, and that's about PPE, that's personal, that's team, that's public. Having processes and protocols, so making the grey a bit more black and white, because it's normally the uncertainty, the not knowing, that cause anxiety and stress in clinicians, and maybe that's what causes the human factor errors. And then talking about communication, teamwork and planning, because I'll just quickly go on to this, because this highlights, if you're in PPE, the difficulties when it comes to communication, or how you need to plan ahead what you're taking into that room with you, because you don't want to be contaminating outsiders when you've been in with a potentially infected baby. And also how that PPE affects your dexterity and your vision. So when you're intubating, for example, and it's thinking about all these things that can affect clinical care. And that's how we created this. And this is one of the flowcharts that we use, is a process really that we embedded into the simulation. So the new doctors, new nurses and the teams who came in at that time knew how to manage cases and transfers if there were concerns and suspicions of COVID. Which leads on to the different other courses that are available, such as NES, which Ravi is probably going to talk about now. Thank you.
Thank you very much, Sinny. So Ashna, you need to make me the presenter, I guess.
Yeah, I think you'll be able to share your screen.
Share my screen? No, just.
Yeah, we can see it now.
Great. Okay. Let me just go to slideshow and then we should start off. Yeah. Sorry, hi. I'm Ravi. I'm one of the consultants, as Syed introduced. So thank you, Syed, and thank you, NQOCN, for the opportunity to share our things, what we have done here, and see how things go, how people can learn from these things. So what I'll try to do over the next 10-15 minutes is to build a story on the NEST, which is the Neonatal Emergency Simulation Training, why we did, how we did, and what we did. But this probably will be the story, as Syed was telling earlier on. Story is one of the powerful mediums where you can take what you want and then use the whole purpose here is the content and the context, which Syed was telling earlier on. The content here is the NEST. So I'm going to just show the story of the NEST. But the context here is that it's open for you. You can take this context and build whatever you want. Just the principles is what we'll be giving out here with them in the medium of a story, but use these principles and develop whatever you want. So that's the whole idea here. And as told, we'll talk a little bit about the NEST and how we did, and then how did we scale up, what were the partnerships we built up, and the CRM principles which I try to employ in building up the NEST. So that's what will be the focus for the next 10-15 minutes. But
sorry to interrupt you. There is some echo at your end, sir. Could you probably use some headphones or something? Because we cannot hear your voice clearly.
Okay, just give me a second then. Let me try.
Yeah.
Let me try.
Yeah, it is a bit better.
Okay, let me try. Nice. Yeah, if you can hear it from that, will be fine.
Much better now. Yeah.
Great. Okay. So let me just go back. So what I was trying to tell was the next 10-15 minutes is just a bit of the journey of the NEST, but more than the journey of the NEST, what I want you guys to focus is the context which I'm trying to get up. The content will remain just the story of the NEST, but context, what you guys can take from this journey. So whenever you want to launch anything, you will have these 3 stages. So the first stage will always be an idea. And from that idea, you need to just develop some prototype. And then once you have a prototype, put it to validation. And once you have this validation, then you start scaling up. So that is how we went through this journey. So let me start with the stage 1. The stage 1 is how we decided on this idea. So we used to run this NEST sort of courses in London, along with Syed, Mark Selwood from UCL, and so on. And that's when I got used to this NEST courses, fantastic teaching. And then I came back to India in 2012. And then working in India, I was thinking there are a few things. Of course, there is a lot of clinical skills here. Of course, a lot of knowledge is there. But it was just a little bit of that implementation, looking into these human factors, which nicely Kedar alluded in his video. And that is what I was thinking, what we are missing, this human factors, and can we bring this aspect into India? And the whole purpose when I discussed with Syed about this was that the 2 principles will remain, is that empowering the people and also improving the quality of neonatal care. So that was the 2 main vision we had. So we have to empower people, and then that should help to improve the quality of neonatal care. So me and Syed had lengthy discussions for a long time. And the main thing is that we just did not bring just the London NEST into India, but we adapted it. And adaptation being simple things. For example, when research call is put out in London, you see a huge, a big team running for that research call. Whereas in India, when I've seen, you probably see just the doctor maximum, or maybe a doctor and a nurse. So these are the certain things which we had to adapt, the case scenarios, we had to adapt the things, what was available here. For example, the dosage of adrenaline vials, how they are available in India. So many things we looked through and we adapted so that the London, the content we could change, but the context was the same, so that we could give this principles of human factors for people. So that was the adaptation which we did. And then we tested our prototype. So the first prototype was the NEST course in partnership with NNF India. It was in November 30th in 2014. Sounds long, but still very fresh in my mind. New Delhi, we did it in Lady Hardinge Medical College. And so we had a good amount of faculty, both trained who are working in the UK, but others who were trained in UK, but predominantly working in India. We had 28 in mind, and as time went on, it became 45. Finally, we had to close the registration, and equal number of people had to be put for the next course. And with the help of Professor Vikram Datta, who was the secretary at that time, and Professor Shikhar Jain, who was the president, we started off the first course in Delhi. And that's a glimpse of the people who were there for the first course. And then the course went very well, and that was the prototype. So we managed to cross the stage 1 of our idea. So we had an idea to a prototype. Now we started thinking, is it valid? Is this course really working? And what are the changes will this course bring about? So we just went into a little bit of feedback analysis. And so most of the people, as you can see, that whichever courses we done, many people would say that it was relevant to their educational needs. And in terms of effectiveness of the course as well, many found fairly effective course. So that sort of gives us the confidence to move on. And then we looked at the human factors. You have been talked about by human factors by Sinny Lau just now. So if you see the blue bars represent what was the knowledge of human factors, sort of the pre-course, and then the red bars represent the knowledge of human factors post-course. And of course, you can visibly see that the knowledge was clearly there, and of course, statistically, they were significant. And similarly, not only the human factors, we looked into this confidence of dealing with emergencies. And again, same results, people clearly saying that post-course, they were much more confident in dealing with these neonatal emergencies. And then the most important bit, which is what we wanted to bring as a part of the human factors, the teamwork, the interprofessional things. So predominantly the culture change in India, which we wanted to gradually bring it about. So the doctors always leading, but at the same time, we wanted to bring the opinion of other allied professionals, nurses who are involved in that resuscitation. And that teamwork was one of the important bit which we wanted to inculcate in people. So a huge amount of feedback. I just put few of the feedbacks which we had received from those courses. So many people telling it was a great learning, a clear thinking and systematic approach, because that framework, how to approach in an emergency was fantastic. One of the feedback which we got. And then of course, many people telling again, a good program, and the same thing is going for the systematic approach, excellent faculty. And then S-bar, which Kedar mentioned earlier on, which is something which is very useful for handover, or also when you want to give out the signposting in an emergency. So these were all the things which we could see from the courses. And then we thought, okay, fine. So we are clearly validating it. And then we went up, we have published this research on our validation. And then once you have done the stage 2, which is basically you've got the idea, you've moved to the validation. Now it was time for us to scale up. And to scale up any project, again, you will require various strategies. And the simplest strategy which we used was collaboration. So we started building a NEST network. and network pan-India. So whomever we were in touch, we got in touch with them and then started working on building this Nest network. And of course, the main thing is that we were only 5 or 6 people when we started off the first course. And then we thought we can't physically be there every time. So it was time for us to get new faculty on board. And then we started doing the trainer of the training courses. And so that was the whole idea, to increase our army, to get more faculty. And then we started planning about the cities where we want to start. So initially we started all the tier 1 cities, all the big players, and then we started moving into tier 2 cities as well. And it was not only just getting the numbers. So as of now, we have done about 62 Nest courses and about 17 TOTs. But the main thing here is that inspiring people, motivating people, that is one of the major ways how you can build your network. And then, as I told, I'll show you some publications. So we started generating publications, which is again validating what we have been doing. And then we started looking out for newer partnerships. For example, we were in partnership for LEDAL for entire 2019. We ran about 22 courses of Nest in partnership with LEDAL. So these are all the newer things which came about by doing these courses. At the same time, we were started expanding. So we looked at other places, and then so as Syed mentioned, we have done Nest courses in Riyadh, we have done in Nepal, and we have done in Sri Lanka. But of course, pandemic has put us to new challenges. So I'll tell what we are thinking about during the pandemic. But this is the scaling up model which we use to move up. So this was one of the TOT courses, and if, as you can see, Kedar, who spoke on the video, this was his TOT in Hyderabad when we got the TOT done. Of course, Amit was one of the other person who was due to give a video, but unfortunately, due to personal circumstances, he could not do it this time. But some of the photos which I used to collect, so it always remembers, for me, the main thing is not just being on the day, it's the day before, which requires a lot of planning and how do you prepare on the day before the course starts. And this is, of course, Syed giving a lecture. This is the core team of the Nest. And then this is on the course from the Riyadh, which we did recently. So this is the publication which we, for as part of the validation which we did, published in the Journal of Neonatology. And again, here we are showing out that at that time we had done about 16 Nest courses, and we are looking at the feedback from people, which included both doctors and the nurses, and what they thought about the course itself. So what's next for us? So the pandemic has put us in a different thought process. So the main thing here is that whenever you have stress, it's an opportunity for growth. That's how we have to think. So you have a pandemic, okay, let's evolve now. So what we have done is that we ran an e-Nest now, and we ran this e-Nest in partnership with LEDAL at JSS Hospital in Mysore. That is, again, I've come back to stage 1. I've launched the prototype again, and let's see how it goes. We've also come up with a master class. We're thinking about how just only using the principles of the human factors and looking at how we can use to a different group of audience here. And that is the master class which we are planning to come up this year. So time for you to keep evolving, because if you remain the same, then you'll be stagnant. So keep moving up. So there's lots and lots of principles in CRM, but what I'll tell is that whenever you want to go through these 3 stages, you will have unique challenges, and to overcome these challenges, you need to know what's your strength and what's your weakness, and that is what will overcome all these obstacles. There are multiple crisis resource management principles. You can use them. What worked for us in this journey? So it's what Syed tells. What were the tools we used for this journey? Number 1, we had a clear leadership. Me and Syed would think through everything, every aspect, and then we would do this way. So we had a clear leadership amongst us, and effective communication, as Kedar was telling it, that closed loop communication. So that was one of the most important way of building up this network. The third thing, which I think is key, is quality control. So what happens is that when you run a course, when you have the 6 people who are at the core, you run a great course. But then as you start expanding, then at somewhere on the line, people forget the ethos. And then we did not want to do that. We always wanted to keep that ethos, that the quality is still the most important thing. So any course, all these 62 courses, we would have one core faculty in the course, because he will know the principles, and he would keep that principles and the ethos together. So having that quality control is one of the important thing, which I personally think was one of the main reason for success of the NEST courses. So wherever you have ecosystem running, think about the ways where you can disrupt this ecosystem. So there was a culture which was there. We tried to do something different from NEST, and which was thankfully accepted very well pan-India. And then that culture of human factors was what we thought to bring about to the people of India. And then always remember, it's just not the equipment. It's people always think simulation is all about the equipment. Equipment is one of the thing, but it's the package. It is how you deliver that course, and then you need to create that magic, because people have to go at the end of this course, wow, what I've learned here is fantastic. It's like a life skill which they can use at work, at home, and so on. So that is the main reason, these are the main tools which we use to create this course. So I'm sure if you guys are thinking up to come up with something, how you can improve the quality of care to your babies in your ecosystem, think about the ways which we'll use. See if you can use any of these ideas, or of course come up with something which you will come up with some other ideas here. So I'm really thankful to Dr. Vikram Datta and Dr. Shikhar Jain, who gave us the opportunity to test our prototype here, and of course Dr. Ajay Sinha, who was closely involved in the first course. So thank you very much. They are my coordinates if anyone wants to reach me out, and thank you for this opportunity. Back to you, Syed.
Thank you, Ravi. Thank you, Sinny, and really thank you for the team who've invited us.